Welcome to Robert Wood Johnson University Hospital Somerset's Health Talk. I am Dr. Douglas Oshinsky of RWJBarnabas Health Medical Group. Over the last decade, the number of cancer drugs has expanded dramatically, and patients are surviving in record numbers. More than 16 million people have survived cancer in the United States alone, a number predicted to be 19 million by 2024 and 30 million worldwide. However, the success in treating cancer is often hindered by the negative effects that some of the drug and radiation therapies have on heart and vascular function. For some cancer survivors, the risk of cardiovascular death surpasses the risk of death due to cancer. During today's show, we will learn more about the clinical collaboration of oncologists and cardiologists impacts the long-term health and well-being of cancer patients. We are pleased to welcome Dr. Mitul Kanzaria, cardiologist at RWJUH Somerset and a member of the RWJBH Medical Group, and Dr. Eshan Patel, oncologist at RWJUH Somerset and a member of the RWJBH Medical Group. Thank you both for being here. Before we talk a little bit about what we're going to be talking about, can you both tell us a little bit about yourself? First, Dr. Patel, can you tell us a little bit about your background and where your practice is and maybe some interests?
Sure. Hello, my name is Eshan Patel. I'm one of the medical oncologists practicing at Robert Wood Johnson Somerset Hospital at Steeplechase Cancer Center. It is a multi-functional cancer center with a lot of different great minds come together and a lot of different specialty under one roof. I have received training at New York Presbyterian Weill Cornell system in Brooklyn, in New York City. I joined Robert Wood Johnson around almost a year ago and have been very involved in a lot of the new pathways for our cancer patients. And my focus is mostly lung cancers and GI cancers. I also do have a lot of training in hematologic malignancies, and those are my most of the focus of practice.
Hi, my name is Mitul Kanzaria. I'm a interventional and general cardiologist located in Bridgewater. We go to Robert Wood Johnson in Somerset, and I also do procedures in New Brunswick as well. I have an interest in general cardiac conditions, including coronary artery disease, hypertension, hyperlipidemia, but also do advanced catheterization procedures, including complex high-risk PCI, which is stenting, and structural heart interventions. Also board certified in echocardiography, and nuclear medicine, and peripheral vascular interpretation. So we have a full range practice here in Bridgewater where we take care of the comprehensive cardiac patient, and now expanding more into the cardio-oncology space, as I'm sure we'll discuss further.
Dr. Patel, can you tell us some of the conditions and cancer treatments which are associated with the cardiovascular side effects?
Yeah, so I think first of all, the conditions. So there are many cancer that can involve the heart directly, such as lymphoma, lung cancer. Those are very notorious to involve heart and the tissue around the heart very, very directly. It can cause fluid buildup around the heart that can cause problem and symptoms. Also, there has been certain blood cancers such as multiple myeloma that cause abnormal protein deposition and cause dysfunctioning of the heart as well. So there are many different cancer that directly involves heart, even without the therapy. So we are always want to make sure and we always rule out if patient have any symptoms or sign that we think patient has involvement of their heart. As far as the cancer treatments, now there are so many cancer treatments. Every day we have new and new forms of therapy. We have moved from conventional therapies to targeted therapies and immunotherapies now. And what over time we have learned that all those forms of therapy do have many different cardiovascular side effects. Conventional chemotherapy that we are aware of that doxorubicin, which usually we give it for breast cancer patient, very well-known agent to cause cardiotoxicity. Also, there are other new agents in a breast cancer, such as trastuzumab, pertuzumab. Those are anti-HER2 therapy for breast cancer patients who have HER2 expression, and those are also very notorious, and we monitor those patients very closely. Nowadays, there are a lot of targeted therapy, and those are the pills that patients take for lung cancers, thyroid cancers, kidney cancers. And those targeted agent, they are under the class called tyrosine kinase inhibitors. We also give those for some of the blood cancers, such as CLL, and those are also notorious to cause cardiovascular side effects. Immunotherapy, those are the new form of therapy, works very well. It primes your own immune system to fight against cancer, and pretty much immunotherapy has making its way in every single cancer. And we have been using it a lot in last 10 years and learning more and more about its side effect. And although it's very well tolerated, but we do see at times, very rarely, but it does have some cardiovascular side effect. It does cause inflammation of the heart muscles, and patients do get those very non-specific symptoms of this heart inflammation. And we are getting better and better recognizing that earlier and treating those earlier.
So tell us, now that we've heard about this, tell me about the collaboration that you have with the cardiologist in helping patients.
So I think the cardio-oncology world is very new. There are a lot of systems that already has good work done and implemented it. Cardio-oncology basically is a collaboration between the cardiologist and an oncologist for all their patients who are undergoing all those systemic therapy. At Robert Wood Johnson, Barnabas Health, it is next big initiative, and we are very lucky. Me and Dr. Kanzaria is on a panel representing Steeplechase Cancer Center and RWJUH Somerset campus, and trying to do a lot of collaboration together under this cardio-oncology work group. And what we're trying to do is trying to come up with the workflows and a way that we can identify those patients earlier who are at risk of developing those cardiovascular side effects. And by having this collaboration early, we can act early. We can refer patients on a timely manner to avoid any catastrophic side effects or major damage. So the collaboration basically working with great cardiologists like Dr. Kanzaria who have interest, and we have a streamline a process how which patients are high risk and which patients will benefit from getting those early cardiology evaluation.
That's a great point by Dr. Patel. We are working closely together to develop protocols and algorithms that identify these patients in a timely manner. And as Dr. Patel said, the sooner that we can identify patients that are either at high risk for cardiac complications or are suffering some cardiac complications from chemotherapy or different agents that are being used, the sooner we can get them on treatment, the sooner that we can change therapies from an oncologic perspective to make sure that preventing of any further cardiac deterioration. In addition, these patients are at high risk of general cardiac complications. So identifying those who are at higher risk, we can screen them for high cholesterol, high blood pressure, diabetes, so on, regular risk factors that increase their risk of coronary artery disease or atherosclerosis as well. So it's been a great collaboration, and we're continuing to build it out further, especially as there's been so many new therapies that have come out in the past few years that we need to keep a close eye on and monitoring for our patients.
So basically, we have a collaboration between the oncologist and cardiologist at the Steeplechase Cancer Center in order to hopefully prevent some of the possible complications from either the cancer or the therapy, and to monitor them both during and afterwards.
That's correct.
Correct.
And something that's really not heard of in many other places either.
Yeah, this is something that's really evolved over in the past few years. And, in fact, when we look at different institutions, this whole field of cardio-oncology is a new field that has evolved over the past, I would say, 3 to 5 years to really develop these relationships, and the data and trials that are available have expanded dramatically in that time period, because we all knew that these patients were at higher risk, but never was really sure what to do. Previously, cancer patients were excluded from cardiology trials, and now there are being trials and studies done specifically for patients with the different oncologic conditions that allows us to tailor our treatments and therapies much better than it was before, and then has spurred this beautiful new collaboration between our two professions to take care of our patients that may suffer some of these cardiac complications from either the malignancies or cancers themselves, as well as the treatments that we're using.
And what's nice is you're not sort of stepping on each other's feet when you're doing this. You're working together on this.
Right. It's a more like a collaboration, right? So I have a patient who I think developing a cardiovascular side effect. I think I need help of Dr. Kanzaria. I think the collaboration helps me learn more about what I should look for in cardiovascular side effect. What are some of the side effects? What is the strain? At what strain I should be more carefully holding the therapy. So I think it's more, I don't see it as stepping. I think it's more like I'm learning, and also I'm sure Dr. Kanzaria is learning more and more about the oncology drug, which ones are causing side effects, and I'm learning more about the heart strain and what it means if the heart strain changes. So I think we are evolving. We have to outside our specialty to at least look for those things and look early, and I think that makes a great impact in a care that we provide to our patients. I think we are able to educate ourselves and help our patients by evolving and learning about this new cardio-oncology collaboration and implementing it here.
The importance is the follow-up, the fact that you're going to cure the cancer. We would like that patient to be as healthy and as stable and as cardiac-wise good health as possible. And by this collaboration, we're going to hopefully give them 40, 50 good years after they've finished therapy.
So that's correct. And there's where survivorship comes along. We have a great initiative also for a survivorship visit. At Steeplechase Cancer Center, we do survivorship visits once patient is done with their treatment. Usually is a very lengthy 1 to 1.5 hour appointment, which goes over what the treatment they got and now what to look for in future, not only in oncology perspective, but other perspectives. So somebody who had breast cancer and got all those systemic therapy, the survivorship visit tells them what are the chronic side effects can be, or what can they develop later in their life and what they look for. And at that time, we go over with the patient the cardiovascular effects in the future, what it can be.
Again, a big change in how we used to do things. When I started, basically we did a nuclear test on them, we got an ejection fraction, we gave them the therapy, and we hoped for the best. What I've got here instead is we've really learned a lot, done a lot, and we have a cardiologist involved to hopefully keep the any type of cardiac disease to minimum and to maximize their quality of life afterwards.
Yeah, correct. And we want to, patients are surviving longer and longer. The excellent therapies that are provided by our oncologists give these patients, a longer prognosis and longer outlook on life. And these patients who have, just like our general population, patients have all kinds of risk factors for development of heart disease, development of high blood pressure, high cholesterol. So it's really important for us to manage those chronic conditions to help decrease their risk of having general cardiac complications, from having heart attacks, from having strokes, having carotid stenosis, abdominal aortic aneurysms, peripheral arterial disease, all kinds of complications that occur from our chronic conditions that are afflicting our society as a whole. So, Dr. Patel's point about making sure that these patients who are now cancer-free, so that we're doing all the other types of screening that we need to reduce their risk of long-term cardiac complications, is really important. And these patients who have malignancies and who have survived from malignancy are at higher risk. It's another risk factor that we use when determining what somebody's risk for cardiac complications can be.
So what should a patient do to prevent and minimize the risk?
So cardiac-wise, regarding to reduce our risk when patients are getting therapies, and Dr. Patel mentioned the variety of, the alphabet soup of therapies that are available now. There's emerging data and literature out there and guidelines that are now being written to show what are the proper screening guidelines, what are guidelines for monitoring their EKGs, monitoring echocardiograms. On echoes, we use newer technology such as strain. Strain is looking at actually the tracking of myocardial movement itself. So how it's not just looking at an ejection fraction number like you were mentioning. It's allowing us to identify patients who may be having cardiac complications earlier, even before their ejection fraction starts to drop. So we've developed protocols of which patients need to be tracked with echocardiograms and how frequently those patients need to be monitored. In addition, with radiation therapy, patients who've had radiation therapy, there can be complications related to that. So we're establishing monitoring pathways for that as well. And then long term, we now fall back on our general guidelines for patients who are cancer-free or in remission of how do we monitor these patients for general cardiac risk factors for high blood pressure, diabetes, high cholesterol, using other imaging modalities we have to really individualize somebody's risk. Not, somebody may have high cholesterol, but how do we individualize what their risk is to having long-term cardiac complications? And we have, newer technologies to be able to do that. So we're implementing those as well.
So it's going back to the basics. That's anything that we do to helpfully prevent cardiac disease.
Yeah, anything we do, monitoring their cholesterol, monitoring their blood pressures, if they have a history of smoking or currently smoking, really being aggressive about counseling them on smoking cessation or other drug usage, keeping their diabetes under control, exercise, dietary changes that they can make. So these are all the foundation or fundamental care that's needed for all of our cardiac patients and cardio-oncology patients.
And of course, if there's a family history, getting them over to a cardiologist to do a baseline testing.
Yep, exactly. Yeah, we do baseline testing for cholesterol numbers. And now, like I mentioned before, individualizing risk, we're using tests such as like calcium scores to see is somebody developing atherosclerosis before they have any symptoms of chest pain or having a heart attack, that we can be really much more aggressive about getting their cholesterol numbers down so we prevent those things from happening in the future.
So I think echoing what Dr. Kanzaria mentioned, I always tell patients that if they are on any of the therapy that potentially causing cardiovascular side effect, I tell them you need to be more well aware and control your other risk factors. Patients who develop the complications are the patient who already have pre-existing conditions, and I think the better way to prevent future complication is by controlling their blood pressure better, their cholesterol better. I advise them different lifestyle changes, exercising. I think those are very basic things, but I think I put a lot of stress on it, and I tell the patient, look, if you're not gonna take care of those basic things, then you are a very high risk of developing cardiovascular complication. And if you develop cardiovascular complication, we might not be able to keep giving you this therapy that might be very efficacious. So I think the education really helps, and we do incorporate a lot of different other subspecialty at Steeplechase Cancer Center, such as dietitian. We will advise them to meet with dietitian. What are some of the changes they can make for weight loss or dietary changes, what they can do to control their blood pressure or cholesterol better. Other than that, I think another major risk I forgot to mention was radiation. So a lot of time patient who has lymphoma or lung cancer who gets radiation into that area of heart are very at high risk of developing cardiovascular complication. And what we try to do with a newer modality now, with the new radiation techniques, we try to minimize the radiation field as much as we can to prevent those toxicity. But yeah, I think the education is the main important part, and I tell patient ahead of time that look, those therapies can cause cardiovascular complication, and I want you to do certain things to help prevent it.
Again, what you're telling us first, at Steeplechase Cancer Center, we have a multidisciplinary approach to medicine. So it's not that we're just giving you medications and watching. We're not giving you IVs. What we're doing is we're working as a team, including the cardiologist now, to help the patient's quality of life after they finally finished all of this.
That's correct.
Which again is a very unusual process. It's not like they're going to a cancer person in the city and the cancer person gives them medication, then sends them home on their way, and then they come back a month later and that's it. What I've got here is instead a collaboration of a full team.
Right. And I think that's a very important for better outcome. I think it's just not giving IV chemo. It's what happens before you receive treatment and after you receive treatment. And you require a lot of different team for a cancer patient. It's already a very complicated disease. And when they get chemotherapy, they need all this different help from dietitian, social worker, cardiology team, radiation team, surgery team. So everything that we try to provide under one roof is very important, is very convenient for the patient. They already have a lot on their plate, and we don't want to make the process very complicated for them. And that's why we have this team approach and a collaboration and multidisciplinary approach for our patients, so they can get everything done in a timely manner and without having to go through a lot of different avenues to get to it.
With a wonderful entry point by having a nurse navigator to help the whole process.
Yes, that's correct. All the cancer patient at Steeplechase Cancer Center has a nurse navigator assigned to them, and they do a wonderful job. The nurse navigator help them guide and literally navigate them through their journey from anything, from having medical to social to psychological, socioeconomic, whatever distress the patient is in. Our navigators will help them, guide them, and find the resources for them.
And again, the other thing I love about the fact is this whole collaboration with the cardiologist. I haven't heard of that at other places, and having a cardiologist on board really improves the outcomes.
Correct. And I think I'll just share one story. We just had a patient who went through the breast cancer treatment, and We do the echocardiogram at a timely manner at certain point of their treatment. And at the end of the treatment, the echocardiogram showed there was reduction in her heart function. I got a call from cardiologist while she was reading the echocardiogram, and I told that the patient needs surgery as soon as we can, so the cancer doesn't come back. The cardiologist team took the patient right away within a week, did the workup, cleared the patient. Patient got surgery without any complication, and we started the treatment after the surgery, and patient is doing very well. If this patient was not in this kind of collaborative system, then I will never have known that there is a ejection fraction has been a little bit reduced. Of course, I will have known when patient came back to me in like 2-3 weeks, but then it will have been delayed in everything. Then I will have asked her to go to a cardiologist. That will have another delayed for 2-3 weeks. And I was able to get the patient to surgery within like 2 weeks instead of 6 weeks. And for some of those breast cancer patients who have very high aggressive risk breast cancer, I cannot wait that long because cancer can always grow back. So I think it was great outcome for the patient. That patient got done everything in timely manner, and that just because of this collaborative effort.
It's been a great collaboration. We're continuing to, I'm learning a lot more about what our cancer therapies and treatment options are for patients, and helping them be one part of their journey that Dr. Patel was mentioning, as well as, these patients who are getting these therapies, need cardiac monitoring and are at risk of cardiac complications, and learning more about what can we do to prevent those things, how can we diagnose them earlier, what are different testing and technologies available to us, and we're expanding that here, including bringing soon to Somerset to have cardiac MRI available, more echo screening. So, we're building on this more, and then, like we mentioned before, the long-term treatment of patients to reduce their risk of heart disease is always a battle that we're fighting and trying to prevent, so our patients can live a long, healthy, pain-free life, regarding both from an oncologic perspective and cardiac perspective.
Dr. Patel, any last thoughts?
No, I think Dr. Kanzaria said it very nicely that this is such a great initiative with the, I will say, cross-specialty learning. I have learned so much about cardiology while going through this whole process, and I'm sure, as Dr. Kanzaria mentioned, he learned more about oncology drugs. And it's good that basic that to learn and to navigate our patient through it. I tell my patient why it is important to follow up with their cardiologist. What are some of the risk factors? Who will develop cardio complication? So it's educating me, and it's better for me to identify those patients much earlier, and through the collaboration I can plug them into this cardio-oncology program. And I think and it's been proven that those patients has better outcome and less complications. So I'm excited for my patient. I think cancer, they get cured by it, but it's always very unfortunate at times when they develop those other complications, and that cause their quality of life to decline. I'm looking forward to make sure that their cancers are cured, and over long term they're doing well and their quality of life is maintained. So that's our goal. And with the help of great colleagues such as Dr. Kanzaria, I think we will have very nice workflow, and we will have a good system in place for our patients at Robert Wood Johnson Somerset.
Thank you both. Thank you both for being here. Thank you for what you do for our patients. Thank you for what you do for RWJUH Somerset, as well as the Steeplechase Cancer Center. And thank you, Dr. Kanzaria, for your cooperation in this cardio-oncology partnership.
Thank you. And thank you, Dr. Shinsky, for the great care you provide for your patients.
Thank you so much for having us, and thank you, Dr. Azinsky.
That concludes today's episode of Health Talk. Please remember that the opinions expressed here today by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call 888-724-7123. For more information about cardiology and cancer services at Robert Wood Johnson University Hospital, Somerset, please visit rwjbh.org/Somerset.